traditional quarterly meeting. I'm Claudia Gualtieri, Chair and at OPM, and I'll turn it to some of our colleagues to do quick introductions. And I'll start with Commissioner Giuttani.
Hi, everybody. Manisha Giuttani, DPH Commissioner.
Claudia, would it be helpful if I call roll and then people can?
Then
okay.
That's good. Thank you.
You're welcome. So thank you, Commissioner. Good morning. Robert Boris.
Here. Present.
Okay. Thank you. Parisa Charmchi Goodwin. Aisha Clark. Ann Foley is excused. Samuel Hahn, Dr. Hahn, I saw you and I heard that you're traveling and unable to. Oh, there you are.
I'm still here. I'll be hopping on and off, but yes, I'm traveling, but I am present. Thank you.
Great. Tony Harp. Cindy Harrison. No, Cindy's here. We were talking grandchildren.
I'm here. Thank you.
Okay. Stephen Hernandez. And Suchitra is excused today. Matthew Jasinski is excused. Commissioner Giuttani. Chris Moran.
Here.
Michael Rell.
I'm here.
Trisha Orozco. And Aisha, I think you just joined us, yes?
Melissa, we had two people admitted while you were doing the roll call. I know Tony Harp has since joined, and Aisha is coming in from the lobby, so she probably is joining in a minute.
Okay, and Tony Harp joined, and Andrew Saltner.
I'm here.
Morning, Dr. Saltner.
Good morning.
Okay, so we now have Aisha Clark who joined, and Tony Harp has joined. All right, Claudio, you have quorum. You're good to go.
Okay, great. Thank you. Just a reminder for today's meeting, we're fortunate enough to have CTN covering this, and they will be broadcasting our meeting today. So it may help if you could introduce yourselves when you speak, and let's also try to mute when we're not talking just to avoid any background noise. Today's meeting will be recorded as is customary for record keeping purposes and for help with maintaining the minutes and doing the minutes afterwards. So now Melissa has verified that we do in fact have quorum, which brings us to the minutes that we'd like to approve from our last meeting. Right after our last meeting, shortly thereafter, Melissa circulated the draft meeting minutes for April 23rd. We circulated those again as part of the reminder for today's meeting. I hope that the board had a chance to review those, and I would now entertain a motion to adopt such minutes.
So moved.
Thank you, Dr. Saltner moved. Do I have a second?
Second.
Motion is moved and seconded. Are there any requests for edits, changes, or discussion on the meeting minutes as presented? Seeing none, let me propose a voice vote to approve the minutes. All those in favor of approving the April 23rd meeting minutes, please signal by saying aye.
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 Any opposed? Any abstentions? All right, so ordered. The meeting minutes have been adopted. Thank you. Quick overview of today's meeting. We're going to start off with some typical updates, our standing updates. The first being an update on the account balance for the Tobacco and Health Trust Fund and any interest earned. Melissa will do that for us. We'll then ask Commissioner Giuttani and the DPH team to give us a status update on contract development for the FY23 Tobacco and Health Trust Funds and an update on the implementation process for the FY24 allocation plan. We'll then have a brief legislative update. We're fortunate enough to have colleagues from DEMIS and the AG's office give us a quick overview of some relevant topics adjacent to the work that the Tobacco and Health Trust Fund does that passed in the legislative session. I'll give a quick update on funding, and then the bulk of today's meeting will be a focus on the continuation of the quit lines implementation of our new provider. So National Jewish Group Health Group took over that contract beginning in January. We had them for an initial meeting. At that time, they didn't yet have a lot of volume data or outcome data. So we've asked them, because their presentation was so engaging and a lot of us had questions, to give a return presentation. So today will be part 2 of that. They're going to update us on utilization statistics and take any follow-up questions that the board has. And then we will conclude, as always, with outlining a few next steps and have opportunity for public comment. With that, I'm going to turn to Melissa Morton to give us a brief update on available fund balances for the Tobacco and Health Trust Fund account. Melissa?
Yes, thanks, Claudio. So I know we usually have a formal report where I share a spreadsheet. There was not much of a change until just the other day when we got an update that we did in fact get another quarter's allotment of interest. So we now have earned an interest since December 31st, 2024. Our unallocated interest has increased as of June 30th by another $269,000. So we now have an balance of unallocated interest available in the account of $826,105.10. At our next meeting, you will be getting again, we'll have a review of the total account balance, including what DPH has drawn down so far to pay our contractors, and a budget showing any unallocated balance that might be left over once contracts have been awarded. We'll talk a little bit more about that later, but just wanted you to know that the next meeting will have a more in-depth budget update for you.
Thank you, Melissa. Good news. It's nice to have that interest balance starting to build up. And I guess that will lead me to kick off a really brief announcement I have with respect to the legislative update before turning it over for a more formal presentation on some policy items that were changed. So I will start with the good news is that the biennium budget that was adopted this legislative session includes full funding of the Tobacco and Health Trust Fund for $12 million in each year of the biennium. Just recall, those deposits typically happen in mid to end of April. So our next $12 million deposit per the budget would be deposited roughly on or around mid-April of 2026, which is really good timing. It'll allow us to get through the 23-24 allocations that we've made and the RFP processes and the contracts. It will also follow the guidance of this board to make sure that we have a little bit of time to evaluate and see some outcome measurements and some statistics on what's working, where there may be an opportunity to pivot and refine, and we'll be on track for the fall of 26 to present a new plan to the legislature. So all in all, good news. And it's also nice that both years were funded. So continued prioritization from the governor and the legislature is very good for our work and good for a continuity of these important services we're able to deliver. With that, I'll turn it to Kelly Cinco, Chief Policy and Government Affairs Officer for DEMIS. She's going to present along with her colleague from the Office of the Attorney General on some enforcement legislation. Thank you, Kelly.
I'm so sorry. I think you cut off for a second and might need to cut you off. Good morning, everyone. I am going to share my screen. It just takes a minute to load to present in Teams. All right. Can you folks see all that?
Looks great. Thanks, Kelly.
Okay, great. Just make sure. Thank you. Awesome. Okay, so just an overview about what we're going to go over today. We'll do some introductions, go over the legislative session overview, like Claudio talked about, and then take any questions. Again, my name is Kelly Sanko-Stuber. I'm the Chief of Policy and Governmental Affairs at the Department of Mental Health and Addiction Services. I just wanted to go over a little bit about what DEMAS does in the prevention arena. We do prevention across the lifespan, even though our treatment and services are for adults primarily. And our prevention division does do tobacco prevention and enforcement, which reduces youth access to tobacco, vape, and nicotine products across the state. We do thousands of unannounced tobacco compliance inspections, and we also work with local prevention councils, regional behavioral health action organizations, and other stakeholders across the state to help with youth access and just tobacco enforcement in general. So that is really where I'm coming from on my role. And I'll be giving the presentation today, but I also have a great resource with me today, Amor. Did you want to introduce yourself from the AG's office?
Good morning, everyone. My name is Amor Rosario. I'm an Assistant Attorney General, and I have been part of the tobacco unit in our office since 2018. I have primarily focused my attention on newer products. I was part of our team that got the Juul settlement, and part of our advocacy work has included some of these successful legislative initiatives that we got passed this year. So I will be here to answer any questions that may arise.
Excellent. Yes, and Amor and the Attorney General's office has been an excellent partner, as well as other state agencies in all these endeavors. So we're very excited to present today and excited to share that there's a lot of attention on these items this session. So I will just jump in. I do like to give people just a little bit of a legislative session stats overview. So there were 4,000 bills introduced this session. About a quarter of them were given a public hearing, a little less than 1,000 reported out of committee, and then 205 bills actually passed both chambers. So some of the bills that you're going to see today, I have multiple numbers because a lot of the things that were tobacco related were put in bills. So that's why you'll see different numbers. But I just like to give people kind of a overview of all the bills that we review and kind of look at over the session. So one of the biggest initiatives was really trying to align the enforcement between tobacco products and electronic nicotine delivery system ENDS for this group or vapor products. So that was both in the budget implementer and in another standalone bill, HB 7181. So the first thing I wanted to bring to your attention is that it was always kind of clear that for cigarette and tobacco products, you had to show ID to make sure you were 21 years of age. We wanted to make sure that they had that same provision for electronic nicotine delivery systems. So that was something we did get past the session. So now the ID requirements for both of those are equal. We did increase maximum fines for underage sales to 1,000. They used to be tiered, but now first time or subsequent times, they all will be an $1,000 fine. So we're hoping that that will help with some of the compliance there. You may also know that the Department of Revenue Services, or DRS, is kind of the oversight for tobacco products. And our sister state agency, the Department of Consumer Protection, kind of oversees the e-cigarettes ENDS. So two different agencies kind of overseeing similar products. So what we tried to do in some of this language was making sure that DCP had the same powers DRS does for tobacco products for ENDS. So now DCP can revoke dealers' registration for violating age verification laws. We think that's very important. And we also made a lot of changes about in-state shipping and transporting of ENDS within the state to align with cigarettes. And that includes deeming these an unfair trade practice, which is a CUPTA violation under DCP. And then some of the other things I wanted to highlight in HB 7181 is we really wanted to increase accountability on smoke and vape shops. So there's a lot more age gating and background checks to increase enforcement and oversight, and also prohibit products that include imitations of food, beverages, or other items that appear to children. For example, this could be if a vape shop was using something like a cartoon character that was popular with children. That's something that now is not allowed to happen. For public engagement on cigarette dealer locations, previously there was some engagement about if a cigarette dealer wanted to locate in a town that they would communicate with DRS. This kind of formalizes that process and makes sure that there is actually a documented back and forth. So now the local police chief is required to send written comments to DRS, and DRS has to send a written response back. So it's really clear that there's a communication loop there that's closed. And it also expands the reasons that residents can formally object to a cigarette dealer's proposed or renewed license. And another increased municipal oversight I wanted to highlight is right now municipalities have certain oversight about what kind of products people can do under a business license, especially ones that are considered an immediate threat to public health and safety, which is the whole list of vape products. So this actually gives much more authority to municipalities to kind of oversee that and weigh in on whether these vape or smoke shops can add more products, and lets them do limitations or also do civil fines if people violate it. So I know that was a really quick overview, but I just wanted to highlight some of the things that happened this session. There were other things that we were trying to push for example, synthetic nicotine or different definitions. And I'm sure we'll continue to work with the AG's office and DPH to keep promoting that forward. That did not go this session, but as a lot of you may know, it does take several sessions sometimes to get an idea through. So thank you for your attention today. And I'm happy to take any questions, and Amor can also help me if there's something more technical.
Great. Thank you, Kelly. Just a couple comments. One, I think it's so important and so much appreciate DEMIS and the Office of the Attorney General being good partners with the board and keeping us connected and informed on not only the funding issues that we more directly oversee, but how it fits into the broader landscape of the changing enforcement regime and the work that DEMIS is doing proactively on prevention. So it's nice to bring all of these conversations together, and really appreciate you being here and sharing the good work that you helped champion this legislative session. I also think, one, you're reflecting a priority that this board has signaled from its re-establishment, and that is understanding the moving landscape and getting ahead of the e-cigarettes and the synthetics, and how do we, to use the Wayne Gretzky quote of not look at where the puck is now, but where the puck will be. And I just appreciate you guys doing that with legislation and updating us on that. So I know a lot of us want to be constructive and helpful partners. This work is continuing, and I'm just really proud that you guys put forward legislation that helped increase the visibility of the importance of prevention, the importance of uniformity across the vape products and traditional tobacco, and pushing the conversation. So thank you with that. I don't know if other board members have specific questions, but we can also send this slide deck around again with the follow-up so that people can look up the Public Act and read the statutes. Do board members have any specific questions that they want to raise at this point? If not, we thank you so much for the presentation and for being here.
Yes, and thank you so much for having us, for those kind words. And again, a big shout out to the Attorney General's office, who did a lot of the heavy lifting about getting a lot of these over the finish line. So we're really excited to keep working with them and all of you.
Thank you for letting us present.
Excellent. Good work. So with that, I'll turn to our next agenda item. And for that, it's Commissioner Giuttani is going to give us an update on the status of contract development for the projects that we funded with our 23 allocation dollars, and a status update on the 24 allocation and implementation. Commissioner Giuttani.
Thanks so much, Claudio. Thank you for sharing my slides, Melissa. So we're very happy to provide this update to the trust fund. So if you can move forward. So what I'll be reviewing is number one, the contract status for FY23 RFP process. And then secondly, the update on the FY24 RFP process. So as a reminder, the 5 different categories that we have on the left are recommended by the CDC, and those percentages are what the CDC recommends in terms of each of the 5 different areas. And as was mentioned before, it was a $12 million allocation. The RFP process went through, contracts were awarded and are in the process of being executed. So that's what's going through the system. And just a few highlights here. We can see in cessation interventions that $500,000 of that was designated specifically to maintain the quit line. And the last category, category 5 on infrastructure administration and management, largely that is funding to help support the work of the staff that is supported by the trust fund to do this work at DPH. And so many of you may remember Amanda Fata is on the call with us. She's helping on executing these contracts, and that's some of what we've spent to date out of that line item. So if you could move forward. So as a reminder, the last time I went over the various steps it takes for a contract to make it from step 1, which is negotiation of contract language with contractors, all the way to step 7, which is the final routing for signatures in the end. And so for all of these contracts, they are in step 4 at the moment, which is to submit the contract to contract management section, or CMS, that is within DPH for processing. This also includes time for OPM approval and budget entry. So as a reminder, all of these contracts the last time we met were in step 1. And so the fact that all of them are in step 4 is pretty much in line with our anticipated time from our last meeting to now to be in step 4. So if you can go to the next slide. We have 7 vendors that are receiving contracts as part of this RFP in FY23 dollars. And you can see here, just as a reminder, a summary of the various different work that they are doing. Some are addressing only component 1, some are 1 and 3. As you can see, component 4 is vendor number 5, which is over $1 million. This is the evaluator. So this is evaluation services and technical assistance to contractors. And so, and then again, just as a reminder, component number 5 is basically the amount dedicated to DPH to be able to do this work. So this is moving forward, and I am hopeful that we will be to a point where by the fall, we have more information for you specifically. What we are anticipating is that the first 4 vendors will be executed by September 1 and the remaining by October 1. So I think we are in line with that. Again, I'm hopeful that with execution of contracts by October, when we get to the April time period, we will have at least some preliminary outcome data to be able to bring back to this board, to be able to have a sense of where things are. And certainly by the fall of 26, it will have been a year that these contracts will have been executed and work would have been ongoing. So the board will have more information on how these various different contractors are actually functioning. So now on to the FY24 RFP. Again, as a reminder, we went through a second RFP process, and also a reminder that if you see from the cessation interventions, there was a $2 million quit line carve out from that amount that is listed there. You can also see that there was a recommended amount by the board of $6.9 million for cessation activities. However, as a reminder, the committee that actually reviewed these applications made a decision to leave an unallocated balance, wanted to see how vendor number 3, who is operating out of FY23 funding and then again FY24 funding, how they will be doing and whether we want to allocate some of these funds to that vendor or somebody else in a subsequent, let's say, process. So again, the percent funding allocation you'll notice is slightly different than it was for FY23. That was a recommendation of this board in terms of how those funds should be allocated. And so we are moving forward with the execution of these contracts. So if you can move to the next slide. As a reminder here, we have several different vendors that are going to be going through the process, and all of these are in step one. So the last time that we met, we were just getting to the point of being able to say who the final recipients, the RFP committee had met. And so again, this is pretty much in line with our anticipated timeline. So you can see here that we have vendors 8, 9, 10, and 11, and the types of work they're going to be doing, which is all of them are the state and community interventions. So you can see those 4. And then if you go to the next slide, Melissa, you can see that the last vendor, as opposed to listing it as vendor number 15, we're listing it as vendor number 3, just as a reminder that they're receiving FY23 funding and then they will receive FY24 funding. And these are, the first one, vendor 12, is also doing state and community work. The other 3 are doing cessation interventions. So those are the updates we have. I believe that this is our last slide, and I can answer any questions that you may have.
Thank you, Commissioner, for that excellent update and all the good work that DPH has been doing to facilitate getting this money awarded, allocated, and through the contracting process into community. A very important step that's sometimes invisible, but critical that we need to have happen. I'll just reflect that I am very appreciative of the evaluation committee's thoughtful approach in recognizing the need to balance innovation and maybe seed some creative projects, but also taking a prudent step of let's get some data and let's not maybe expend everything for something that we don't have a lot of data, statistics, and outcomes for. So I actually think that's a real growth point for the evaluation committee, and I'm proud to see that reflected in our work. We're always being good stewards of these investments and balancing that need to try some new things that may or may not work, but also do so in a scaled approach. So that stood out to me, and I wanted to commend the group on their work. Any questions or follow-up comments from the board?
I'll just take a moment to thank the DPH team who's on the call. We have Julie Vigil, Allison Sullivan, and Amanda Fata, who've been working to get these contracts executed. And I am proud of the fact that they've been able to stick with the timelines, and our entire DPH group, including the contracting group, who's been working to get this done. So I know it may feel a little bit like we've done a lot of work to identify the vendors, but it does take time to get these contracts executed. And hopefully by the spring, we'll have even more information, because I think in the fall meeting, we'll just hopefully have our first round of contracts executed.
And I see Mike Rell is looking to get recognized. Go ahead, Mike.
Thank you, Claudio, and thank you, Commissioner. And actually, you just answered it. When would the contracts likely be executed for these that are, I guess, on slides 9 and 10?
Right. So 9 and 10, if we go back, those are for the FY24 funds, right? So that's going to be a little bit further out. So as you can see, our anticipated timeline in general is 8 months. And so given that they're all in step 1 right now, I would say in the 6 to 8 month time period is what we should be looking at in terms of execution.
Okay, great. And these dollar amounts on slides 9 and 10, they come from and if you go to slide 8, the 10.155 million, or are they, do they also include the 2.4 million?
Right. So in slide 8, what you can see is that in the column 3, the board recommended allocation amounts based on the state authorization. So this included the 12 million allocation plus, I believe, Claudio or Melissa, you can correct me, but potentially interest or other remnants that were left. So this was what was available. But in column 4, the total amount proposed by proposers was 10 million. So we didn't even receive proposals of up to the 14 million that was allocated. So then in column 5, the total amount awarded is a little bit more because I believe of the carve out for the quit line, that 2 million for the quit line, which is why it's more than what the proposed amount was. But then also, even though there was additional money, as opposed to just giving it to a vendor who didn't even ask for it, the decision was made to leave an unallocated balance that could be reviewed after we have some outcome data to determine what to do with that.
Gotcha. Okay. It sounds great. Very good. Appreciate it.
Thank you.
If there are no other questions, if I could ask Commissioner Giuttani to introduce our Quitline vendor for their 2.0 presentation and follow-up today.
Great. So yes, we're very excited. I was really intrigued to hear their presentation the last time and hear many of the details. And so really looking forward to hearing from them again, specifically about their part 2 presentation. And again, just to reiterate, this is National Jewish Health, who is our vendor doing this work, and would like to turn it over to you.
Yeah, good morning, everyone. My name's Dave Woodruff. I was here the last time. I'm the representative and account manager for National Jewish Health. I'm going to go ahead and start sharing my screen while I talk. And it looks like we're ahead of time, so I don't have to speak at lightning speed, which is always a nice thing. Bear with me just a moment here. And can everybody see the presentation? Cool. All right. So yeah, as I mentioned, my name's Dave Woodruff, I'm account manager here for the for National Jewish. We are located in Denver, Colorado. I'm just moving a little thing over here. So there we are. So we were founded in 1899. This is a little bit of a recap for everybody, but back in 1899, it was at the height of the tuberculosis crisis. So we really have been that pulmonary hospital that helped back in those days, where folks, the clinical aspect was to have the fresh air and the high altitude and the sunshine and all that great stuff. So that's really where we started, and obviously we're just continuing that work as we move forward with Tobacco Cessation work as that nonprofit academic medical research facility, where a lot of our pretty much everything that we're earning is going back to research for additional programs. The program itself that we have here for Connecticut and also for 25 other state partners across the country is primarily our phone program. So it is a phone cessation program, and we're going to talk about web in a little bit as well, but it's with our tobacco treatment specialists. We also offer that variety of a digital suite of services as well, which of course includes our web program, email, text messaging. All those things kind of encompass into our digital suite. We also provide out to the participants education materials. So as we go through our coaching or as our intake process, we identify certain triggers or certain behaviors or certain conditions, and then that more personalized material is sent out to the individual either through mail or through a link so they can access all that through our online platform as well. And then we're also offering nicotine replacement therapy or NRT for participants as we move through the program. Our service is available 7 days a week. We do have a couple days where we are not in person, and those, of course, are Christmas and Thanksgiving. All others, we are here. We have some limited hours, but our online services are available 24/7. All of our coaches speak English, of course, and then we have a good amount of coaches that speak Spanish, and then we have an additional 200 languages that are offered through our translation services. The program itself for Connecticut is again, the phone program. It is for anybody, any age can participate in our phone program. So if they call, we will certainly kind of engage with them. NRT, however, is only for folks at this time for 18 and older. So if they're 17 and under, we would actually refer back to their provider for any kind of NRT services for that. There's a couple ways that they can get into us as a self-referral. They can certainly call us directly, the 1-800-QUIT-NOW. They can go online. Again, we're going to go into a little more detail on what we currently have for our online platform because we did recently update that. But they can go online, they can enroll, they can stick on the web, or they can actually ask us to call them, and which we would also do. So, or they can have a combination of both programs. They can be referred to as provider. Highly encourage that, obviously. We receive those all the time from fax and web. And then we also will work with the state and the clinics and the providers locally to set up an e-referral so that we have that direct link between the provider and National Jewish Health, so we can have those referrals come directly into the system. We do have a specialized phone number and web program for the My Life, My Quit program. That's our Youth Sensation program, and that is for the 17 and under age group. The base program that we have, the standard protocol, is a 5-call program, not including the initial intake call. So we'll bring everybody in when they first call or when we first interact with them. We go through an intake process, which encompasses quite a few demographic and medical type questions. And then we get them into a coaching session. And so those are up to 5 in our base program. However, there is unlimited support if they have additional needs, or if they feel that urge and they need to call and talk to somebody. We're certainly there to interact with them. We do schedule those, so they are typically scheduled about 7 to 10 days apart. So as we go through that first coaching call at the end, that is that final step where we will schedule the next call. We will then try to make those 3 attempts. If we don't pick them up the first call, make additional 3 attempts to continue to engage with the individual. But once they finish the 5 calls, then we consider that a program complete, and then they kind of graduate, which is always nice. As I already mentioned, the English and Spanish, and that we have the 200 additional languages or over 200 languages via the translation line. Some of our additional programs that we're currently offering within the state is the pregnancy postpartum program. So that's a little bit of a specialty one, where it's a 9-call program. And what it consists of is 5 calls during pregnancy. So of course, if somebody calls and they indicate that they are pregnant, they are offered to partake in this program, and then they receive the 5 calls during pregnancy, and then they receive an additional 4 calls during postpartum, so that they can continue that support. This program, unlike the other one that we have, the standard protocol, has a dedicated female coach that the individual would talk to. So they're partnered with the same coach throughout their journey. And so we do find in that particular situation that it is more successful for that population when they're always dealing with the same person. Now, the only caveat to that is if they call during an off-cycle call, obviously the coaching call themselves would be scheduled. If they're calling during an off-cycle, then they might not receive the same individual, but the next call, the coaching calls themselves that are scheduled out, would always be with that person. We do incentivize this program for Connecticut. So right now, if somebody's completing those calls, it's a $20 gift card that is sent out to the participant for their pregnancy calls, the 1 through 5s, and $30 gift cards for their postpartum calls, the 6 through 9. Again, I think, we talked about a little bit last time as far as, we've seen that additional coaching calls coupled with NRT, which we don't offer with the pregnancy piece. We can talk about that, but that actually encourages that quit rate and increases the quit rates as they move on. So incentivizing is that way that we can kind of keep them a little more engaged with the overall program and into that next call as we move forward. I kind of touched on the NRT. It's not something we currently offer or usually offer directly to folks who call in pregnant. However, there is a medical clearance form that we can work with their local provider to clear them for any NRT usage so that they can continue to have the NRT. But postpartum, they could. As I already kind of mentioned, in My Life, My Quit is our youth program. It's a little bit of a different program than what we have for the adults. It was something that was really fine-tuned by youth. We've engaged with youth over the years to ensure that we have a program that they are wanting to take part in. A couple ways they can actually get into us, which is a little different than other. They can text our short code, which is 36072 for the youth. That does get them enrolled and getting them started in a motivational text library, and then it encourages them to engage with the overall program. They can also call us, and there is a dedicated number for that. But if they call the 1-800-QUIT now, we'll certainly get them into the program that way. And then the My Life, My Quit is the website, the dedicated website for that program. Again, they can call in, go onto the website, or use that short code to get started into the program. A little bit of a different animal here, because instead of 5 coaching calls, this is a 5 coaching session program. So they can have those sessions for phone, text, or chat. With anybody with teenagers knows, they don't like to seem to talk on the phone, because I have 2 and they never want to talk to me. But they'll text me all day. So that is something we did with this particular program. That is something that we've been learning over the years, that the texting coaching through texting is a much different interaction than you have with phones. So we continue to kind of fine tune that program. It is also a simplified registration and intake process, meaning that we don't go into insurance questions and we don't go into a lot of the medical questions that we typically would with the adult. We're trying to streamline it for that youth population so that they can come in and take part in it. All of our promotion and educational materials was developed and reviewed by youth. So we continue to try to keep that group and that population involved in the overall program. And then, addition to this, those 2 programs, of course, we are offering NRT, throughout the community, and that is available to all residents of Connecticut. The NRT itself, though, is available once per year, so people become eligible once per year. Currently, as of today, we are offering 6 weeks of patch, gum, or lozenge. Our web program recipients, they can get up to 2 weeks of a monotherapy. That was actually something that we started back in December, so it wasn't since the inception of when we took over the Quit Line, but something we layered in, which again, we find that engagement, we're trying to get that into the hands of the individuals. And then we also have that combo therapy available. So combo therapy is when somebody is getting that patch plus a gum or lozenge, so they can handle the long-term kind of interaction with the patch, but also be able to partake in the short-term craving through the gum or lozenge. So that we also find helps. Now we are updating that. We're in the process of doing that almost as we speak, where we actually are going to be increasing our NRT offerings with the state's approval to an 8 weeks offering to all participants of patch, gum, or lozenge, again, including the combo therapy. And our online NRT offering will then also encompass combination therapy. So when folks are calling in, they'll be able to get combination therapy through the web program. So those 2 things we're looking to have kind of turned on within the next week or 2 for the state and for anybody who's going through the program. If we get to that point where the participant doesn't have an additional NRT availability, under the program, we do encourage them then to call their local insurance or their private insurance company for any NRT or future NRT support. If they're, get to that point where they're just, they're not getting anything, we will then escalate it back to the state and see, hey, is this something we kind of want to override? So there is an escalation process for that, but at this point, they are eligible once a year for the 8 weeks of NRT, at least within the next few weeks. Something else we're going to be layering in. This is not something in place today, but something that we will be doing soon. This is something we have been talking about and will be pulling in is our lung cancer screening program. What this program does is through the intake process. We identify their age, of course, and something we also now layer in is their pack usage per year. So as we identify those folks who are between 50 and 80 and have a 20-year pack history, then they are eligible to receive the information. And so it's an opt-in type of program where if we will identify the individual based on that criteria, we will then ask them, do you want to hear more about lung cancer screening? I think we're trying to change some of that language over to lung health screening because cancer seems to be that scary point for everyone. But we would then be able to provide them with the resources. We actually link them over to a site, and we have partnered with MD Anderson to be able to do that. It's something we will layer into the QuitLogic site, to the website itself. In fact, I'll kind of move into our next page here so you can see some of that. So that there is the screen for the MD Anderson, but then it gets layered into the QuitLogic's site for Connecticut. We will then identify that individual. We'll ask them if they want to hear more about the information, and then we direct them towards this screen, so and to this page where there's different tools that they can go through, and they can be able to identify, you know, what's their risk level, what kind of resources are available in their area, and so forth. So it gets them into that look of what they can do next. It's certainly something as an ex-smoker that I've taken advantage of to know kind of what my risk is too. So this is something that we'll be launching. It's not something that's immediate. It takes us a little bit because of the web programming, but probably within the next few months we'll have this in place. Our utilization now, believe it or not, we just went by our 1-year anniversary for Connecticut launching with National Jewish, so we're kind of excited about that. That was yesterday, but within this past year, pretty darn close. We were at 967 phone intakes. So 967 people called us from the state of Connecticut. Great news. And then, but we had over 1,000 people actually enroll through the web. So you can see, you know, there's some differences there, and we're seeing that, I think, more and more over the years as we've seen a decrease in the phone program. Not, you know, significant, but, you know, 2, 3, 4% per year. But we've seen an increase in web volume. So more and more people are heading towards the web than ever. And that's kind of a precursor to some of the work that we've done more recently, which we'll also get into in a second here. But our program enrollment, when we come in from the providers, of course, we are trying and still working to bring on our first e-referral into the program in Connecticut. So as of this time, we've not had any e-referrals because we haven't had any set up. We have had 16 fax referrals and 32 of the web referrals. Our digital services, we've actually enrolled just about 1,300 text participants and 825 email participants. Those can come whether they're through the phone or the web. So whichever direction they come in, they can opt into those programs. And they are more of a motivational kind of a text library or email library where they go out on regular intervals and towards the person's, whatever the demographic that they identified through that intake process, it will be a little more tailored towards that. Coaching calls, we've had 812 of our first coaching call, and then over 1,000 on coaching calls 2+, meaning those 2 through 5 calls. We've had over 1,000 of those. And you can see with the NRT numbers, we've had a total of 1,500 or 1,570 NRT units ordered. So that's whether it was patch, gum, or lozenge, or one of those combo therapies I was mentioning. It's been close to 1,600 actual units. 1,200 of those were through the phone. So when they call us and we engage with them, those units were sent through the phone. But 350 went out since December through the web. So that's also great because we got another 350 or so folks who are receiving that NRT over the web. That's that engagement. That's getting them started in the program and you know, kind of building that success rate for them. This is kind of the breakdown of where we kind of saw the numbers. I think, you know, one thing I'll kind of point out, we're seeing some of those larger numbers as we move in to the at least on the digital side. We saw some really great numbers in the second half of the last calendar year, and I know that there were some promotions that were being run locally. And then as we moved into the the second part of the first part of the 25 calendar year, we're seeing a little more of an uptick in the phone. That is primarily driven by the TIPS campaign. So the CDC TIPS campaign, which comes out and it did launch in March, we typically do see more of an increase on the phone side and a decrease on the web. But overall, we're seeing some decent numbers as we kind of move through the year. And you can also see where we've had that increase since December, where we started launching or kind of putting it out there to the web. So our patch take rates have certainly increased since that December period, where they're now receiving it through the website. So next, I wanted to kind of really talk more about some of our redesign program with our QuitLogix web program. It is something that we just launched in May. However, we've been talking about it for quite a while. So just to give you a visual here, this is what we used to have. So this was a site that was developed, I think it was 2019 or so, maybe even 2017. And it was okay. It was a pretty, I want to call it basic site, but it was a site that, provided a lot of information. It was good at the time. But, we started receiving that feedback, and we did have quite a few user experience studies that we conducted to identify, where were the struggles, why, how can we improve the site? What can we do? So we're breaking it into two kind of components, or talk about in two different components. We have our public facing pages, which is you kind of would see on the left-hand side. But then as you enroll and you get into your private pages, that also is something that we were focused on. So that on the right-hand side is more of what the participant would see. And a lot of the feedback we received, while the information was good, they didn't know what direction to take. They didn't know what the next steps were. So they would enroll, we'd see their enrollments. That's great. They might kick around the site a little bit, but there was no real true direction. So what we've moved into at this point, and we launched this for Connecticut in May, is a site that looks a little more like this. This is something that, again, as we worked with those focus groups and we talked to them and we incorporated a lot of the components that they were talking about, this is kind of the direction we went in. And so this is obviously branded. This is right now branded with Colorado's Quitline, but the Connecticut Quitline has their own brand, their own logo that's been attached to this, along with some of the customization that we were able to do with the pictures and the colors and all that great stuff. But it was designed to streamline their experience, the user experience, so that they could engage with us. And then the other piece here is that this was designed as mobile first. While our former site was mobile friendly, this was actually designed for a mobile phone first, so somebody could actually engage with it on their phone. And then we re-engineered or backwards engineered it into a laptop or tablet or whatnot. So, so that's kind of how it starts. Most of the work, however, was not done on the front pages. Well, the front pages were streamlined. The intake process, or I'm sorry, the enrollment process was made a little more seamless for everybody. Where we really updated it was on the back side, and that's on our private side. So when somebody enrolls in the program, we're really looking for what they can do. So we updated our enrollment within this, and I'm not going to go into too many details here, but we updated the enrollment side. We created tutorial videos so people knew what their next steps were. They are able to customize their program so they can set the milestones. So instead of just having, hey, here are all 20 different activities you can do, we've set milestones so they have little components throughout their journey. So kind of similar to what we do a little bit with the phone program, where, hey, we do a check-in, then we have a call, and then we do another check-in, and we kind of gear them towards that. This is what we've all tried to design this a little more towards on the web program, with so many people going towards it. I don't know why that clicked in. So as I said, they can customize their program a little bit more. They can pick their quit date. They can define their reasons. They can do they kind of decide what their rewards are. They can even identify their triggers. There's a lot of different things that they can do to help to customize this. They can add support people. So if somebody and it's not as robust as you might think, where it comes to like Twitter or any other social media. Is really just a thumbs up. And when somebody says, hey, I hit a milestone and I'm 30 days quit, they get a little thumbs up from whomever might be following them. So it's really an opportunity for them to be able to customize and make it more worthwhile to them as an individual. As I said, check-ins are something that's new here. So they, instead of just, hey, whenever they get back, they get back. In the old program, this is more of a defined check-in type of a process. So they go for, again, they define it, but they can say, hey, in 2 weeks, I want to check in again. And at 2 weeks after that, and every time they check in, they'll have those new activities as long as they've completed their old. So it's a continual process for them to get through it, and they can see their progress as they move through. When they do complete, and that's the hope here, is that they do complete all these programs or all these activities, they will then have completed the program, and then they actually will receive a completion certificate similar to the phone, but not quite. But then they'll have that kind of paper to kind of congratulate themselves that they've actually completed everything through. I'm going to jump into the My Life, My Quit, because we did a very, very, very similar thing with My Life, My Quit, but with a little bit of a different emphasis, because obviously, we did not believe, and we still don't, that adults can necessarily define or design a website or a program directly for the youth. Since they would just kind of dismiss the whole thing. So we, instead of engaging, obviously, with our user experience groups with adults, we did that with youth. And then we've also been coupling with a youth advocacy group here local in Colorado. So as we went through this process, we are continuing to engage with them to ensure that this is kind of what they said. So this is what they used to have, or this is what we used to have with the My Life, My Quit site. They did not like it. They felt, I learned the word sus from them. They felt it was suspect. They didn't like people staring at it. They didn't like the pictures. Well, it's funny because on the adult side, our adult user experience, they said, no, they want those hero pictures. They wanted the people on there. The youth, they didn't want this as much. They also had very similar feedback. They did not know the direction. They did not know why that we were looking for certain pieces of information during that intake process. They did not know what to do next in their program. So that's where we, again, focused a lot of our attention into is kind of in the behind the scenes. Also just happened to be that we launched this in May. We actually, on the adult side, we were kind of a phased approach on the launch, and My Life, My Quit, since a national program, we did launch it all at once in May. So both the adult and the My Life, My Quit site launched in May for the state of Connecticut. But a different look and feel. This is their feedback. This is what they wanted to see. Again, this is designed similar to what I talked about with the adult site, where it is a mobile first design instead of a mobile friendly. This is something for them to pull up on their phones, when they're in their class or wherever. Not that they would do it in the class, but they would, can certainly be doing it wherever they feel fit. And we streamlined some of the intake process. Again, we didn't try to kind of force them into it. They find it. It's a little more, the verbiage is a little more intuitive to what they want to know, as far as, how they, or what it's going to mean to them. Again, these are some of those back private page type things. It is very, very similar to what we've done on the adult site, but it's more designed for them. So you can see on those tutorial videos, those are not the same look and feel. Those are completely different videos for the youth, and speaking more towards what they feel that is important to them. We updated their enrollment page, so it's the personalized. Again, that was some of that feedback that we received initially from the youth as well that we received from the adults. It is, again, the interactive piece of it, but again, different look and feel. It's more of a gamification for them. So it's kind of setting their rewards is a little more prominent with these types of things, and giving them those milestones as we move through. So those are our two programs. Those, again, just launched since the last time we talked. And then I'm going to move into some of the pieces that are available that I think we're talking through to see if this is worthwhile for Connecticut to launch here. So the first one we'll kind of talk through is, I want to say it's similar to PPP. It's like the pregnancy postpartum program, where it's a layered on approach. So it's the behavioral health protocol. This is where, when we are going and engaging with the participant as they call in on the intake, that we are now identifying, or we are talking to them about different behavioral health type situations. And then we look for 7, really. It's PTSD, schizophrenia, ADHD, anxiety, depression, bipolar disorder, and substance abuse. So if we identify a participant, and again, it is something that it is self-reported, it is not something where when we are asking for a referral from a provider, that diagnosis code or anything like that is being presented. It is completely self-reported. But if they identify themselves as somebody who has one of those 7 situations, we would then offer this particular program. It is an opt-in program, so it is not something that they have to go into. But if they desire, if this is something they want to move into, this is something they can do. This is actually a 7-call program, so it's a little bit different than our standard 5-call program. The coaches themselves, it is a different subset within our coaching population, where they have received some additional training on some of those more specialized pieces to be able to help with those participants in getting through their cravings and their urges. But it does look at a 7-call program, and it is really the 5 core calls within the standard protocol, but then it layers on an additional 2. So they're check-in calls. So we go through the 5, and then about a month out, we will schedule another call with that participant to see how they're doing and keep them engaged. And then we'll schedule another call a month after that. So they're the 2 additional really check-in calls on the backside of that program. We also look, and right now we're offering the combination therapy, but this is one of those programs where we highly encourage combination therapy. We have found that the most success rate for that population group is when they are able to not only handle the long-term craving, but also those short-term urges through that combination therapy. So this is a program that, again, we are, certainly talking about and something we could layer in very quickly into Connecticut. Another program that we offer and can certainly talk about, we call it QuitLogix Education, but it is an education platform that we layer in really into the website, where this offers accreditation classes for CME, CNE, and CPE. They are, again, modules that are loaded up. There is one customized module, and that is, obviously for Connecticut. That's one of the reasons that the launch on something like this is a little bit longer. There's a little bit longer runway because there's development time on that particular program. But it is an annual one-time fee. There's nothing additional beyond that over the course of the year for as many people that want to go through this. I've even had some states where they've encouraged not just for the medical community, but actually their schooling too. So they've actually approached their administrators within the school systems to take some of these classes so they can learn more about tobacco and the effects of tobacco. So this is also something that we have kind of sitting out there that we could also launch within the state. And then the next piece I'll just kind of touch on are just evaluations, something that we also do. I know, there's been some talk and going back and forth. This is the evaluation program that we currently offer or that we currently do. We do different formats in different states depending on kind of what they feel is necessary. We do use a third-party evaluator for our phone surveys. It's Westat, where they are attempting those. It's up to 7 outreach attempts on our normal program. That success rate is okay. It's usually around a 20% success rate on reaching those folks and getting that. What we also encourage a lot of folks to do, and obviously there's a little bit of a higher price tag to it, but it's the enhanced program where we're doing a pre-notification letter, we're doing 10 outreach attempts, and then there's actually a gift card incentive for those people. And that's where we start getting into the 30 to 40% success rate at connecting with those individuals on their journey. And so these are normally conducted 7 months after the intake process, so that it's based on the intake. It's not based on the program complete. It's not based on engaging within any of the programs. It's actually once they engage with an intake. Once we have their information, one of the questions within the intake process is if we can contact them, and whether or not they go into that first coaching call or all coaching calls, we're going to outreach them to get their feedback on the overall program. So that's on the phone side. The web survey, we also offer that, and these are always layered upon items. We can do one or all or none. But on our website, again, we have those 3 surveys or the 3 attempts. They go out through email or text. Obviously, if they're just web surveys, and these are folks that engage primarily with us through the web program, so we know they're not going to want to take a phone call. So we send them through the text and in an email with a link to the survey. Not a huge success rate, as I'm sure you can imagine. It's, I think, less than 10% is what we typically see with those web surveys. But on the enhanced side, it does click up a little bit because, again, we're linking a incentive, a gift card incentive, so that there's a little more of a reason for them to complete it. Another layered approach that we also offer is an outcomes report. So after we've conducted our surveys over that period of time, so that 12-month period of time, then we will go ahead and compile the outcomes report and provide that back to the state for their review. And I think I'm hoping I'm at my end of my time, but that's the presentation today. And I think we touched on everything, but are there any questions that I can answer for you? I'm going to stop sharing.
Yes,
well,
I think we do have some questions, and I will first recognize, I see Representative Harrison, please.
I'm going to say, wow, thank you for all of that information. No, I work in here, trying for you to see me, as long as you can hear me.
I can hear you. I can hear you.
And I certainly don't want to be the person to take up all of the time. I mean, I have a list of questions. And since I see that the commissioner has questions, maybe I'll ask 2 questions because they kind of link with that. One is, I don't know if DPH has any estimate of the number of smokers in Connecticut, because it would be interesting to link that with the number that are calling in and trying to quit. And certainly we're only launching these programs now, but I think that would be interesting data. I see you shaking your head, so thank you. And I think the second piece is, while we allocate money and as we get data, and they certainly have a component for continuing education, we have many providers out there who I'm sure could benefit from knowing what's available. And again, this is, I don't know all the details of what they need for their, CPE requirements, but is this something that we could incorporate into what they're allowed for CPE requirements, and perhaps allocate some of our money to allow them to take this class for free, because, or allocate money, because certainly, as we know, our cancer, our cardio, some of our pulmonary providers could really benefit from being able to maybe guide some of their patients in this direction. I have many other questions, but I know other people are also have questions, and maybe they'll answer the same ones, but certainly would appreciate, Commissioner, maybe you incorporating that or providing feedback. Thank you.
So I don't know if the question necessarily were directed at me. I can say that I agree. It's very interesting data to see kind of the success rate of the programs. That outcomes report that I alluded to, that's typically where we start doing some of that research, so we can see it's really that long-term impact of the program. What's the quit rates for the folks that are going through the program, but then also how many people have we connected with compared to the population of the state. And then it goes into a lot more demographics when it comes to population by county, at least. Now, I can say with that particular piece, and I know the state is working through some RFP processes, but we can do one, all, or none of those. Again, we have some states where we are providing that raw data file of participants who have gone through the program to another vendor, so that they can then conduct those outcomes reports or outcome surveys. We actually do some of that work with the outcome surveys and then provide it to another vendor to do the outcomes report itself. And in other cases, we actually are doing all all the work. We're doing the surveys or managing through the surveys, and then also doing the outcomes. So there are certainly different layers that we can bring up within that piece. And yeah, the QLE piece, it's pretty valuable, to get out to the population, and certainly something we can layer in. Sorry if I spoke out of turn. So.
No, not at all. And I want to recognize Commissioner Giuttani, who has her hand up for a question as well.
Great. Thank you, Claudio. So a couple of points just in response to those questions. In terms of the number of smokers we have in Connecticut, I don't have that information offhand. Our team may have some of that data, but how we generally estimate that is that we get funding from the CDC and use other federal dollars that we get as well at the moment that we receive to do a survey called the BRFSS. It's a behavioral risk factor survey. And then the YRBS, which is a youth risk factor survey as well, behavioral survey. And in those surveys every year, there's a subset of the Connecticut population that is called. It's a representative subset. The YRBS is actually done in schools. BRFSS is a phone call. And from that, from the questions that are asked regarding tobacco, we extrapolate how many smokers we may think we have in the state. So I don't know the exact numbers based on the BRFSS or YRBS surveys that we've done in the past, but that's part of the way. And I'll ask our team if they have any answers on that. Secondly, around the QuitLogix education, certainly that is something that this group could evaluate if that is something we want more information on or want to consider funding in the future. That is something that this body, can discuss in future allocations in terms of how we want to do that. And then the last thing I wanted to comment on was the evaluator contract that we have as well. So as you recall, there are those 5 categories that I mentioned. And we've got the FY23 where I talked about category 4 being an evaluator contract that the RFP committee that, this group helped support evaluated and identified, and that contract is under execution. So that will be part of evaluating our greater programming. And, as we start getting information from that, we can bring that back to this group and discuss how we want to move forward. So I want to get to my question now, David, if I wanted to know if through any of this, you actually have any information at all on how many people actually quit and the sustainability of that. And do we have any actual participant data in terms of people? We know the number of people that made it through the program, but how that actually impacted their behavior. Do we get that from anywhere?
Not currently. So that is part of that evaluation work. So, we follow those NAAQS standards. So it's a 7-month survey evaluation. If we were to turn that on, we would then be starting to engage with people that had completed, and not even completed, but entered the program 7 months ago. So that's where we kind of see that success rate is through the evaluations.
Okay, thank you. And so I think what's important to highlight there, and that we'll have to go back and look into a little bit, is that I believe that our evaluator contract is more on evaluating the interventions that we're putting into effect and the contractors that we are contracting with and how well they are doing and meeting the outcomes that we have. And we'll have to look at a little bit more, and I don't know anybody from DPH if they have information. I do not believe that 7-month surveys of actual participants is part of what we're calling an evaluator contract. So if anybody from DPH has any information on number of smokers we have in Connecticut or anything about the evaluator contract, feel free to chime in. Otherwise, we'll
Commissioner, I can answer on the number of smokers.
Okay, go ahead, Julie.
So in Connecticut, 17.1% of our population, or 465,400 adults, use some form of tobacco in Connecticut. As far as the evaluator contract, I'm going to defer to Allison Sullivan, the program supervisor who was part of the RFP and negotiation process.
Sure. Hello, Allison Sullivan. Yes, so we are making sure that there would not be overlap as we consider the evaluation services of National Jewish Health. We are looking at items like the 7-month follow-up with a survey, with incentives, really those surveys to give us that information. That is not something that our evaluation contractor would do. They would be evaluating more services overall for every program. So I don't foresee overlap there. So I think it is a consideration as we continue to follow closely with the budget to see whether this is something that we can consider. I hope that answers your question.
Yeah, thank you, Julie and Allison. That's what I thought, Allison, in terms of the evaluator contract. So thank you for confirming. Okay, back to you, Claudia.
Thank you. And as we expected, lots of questions. So you always engaged our group, David. I'm going to go to Dr. Salner, who I see next, followed by Tony Harp.
Thanks, Claudio. It looks like Dr. Hahn may be ahead of me, actually.
Oh, thank you, Dr. Salner. A quick question. Oh, I don't know how quick it's going to be, but a question for Claudio, the commissioner and this group. This sounds like it's an amazing program as a provider, and then now also wearing my health system hat representing Yale New Haven Health. I would love to be able to put this on every after visit summary for patients who are smokers, right? I mean, we basically, the medical assistants, when they room a patient, ask the patient, are you a smoker? They answer yes or no. And we could certainly very easily automatically insert this into an after visit summary, as well as build an ambulatory referral in Epic to the quit line if they're able to accept these sorts of referrals. Is this something that the group thinks we should do? And if so, I'm happy to help execute it from Yale New Haven Health. And I think we should then also obviously look at the other health systems in Connecticut.
Commissioner, as the subject matter expert, I would defer to you. I generally think as a voluntary basis, the more we spread the word and create soft linkages into easy referrals and streamline that process is a good thing. I guess my only hesitation is to make it a sort of a heavy mandate, knowing how many questions and burdens and other prompts clinicians have. So mindful of that, to the extent that people want to voluntarily use this resource and we can nudge it along, I think that's a welcome idea.
Yeah, I would just second that. I mean, you know, an after visit summary, having a little bullet about, you know, the quit line, and you can call this number or text this number or something like that. That's not a very heavy lift, I think. I don't think that that should be a problem, I would think, from the health system or provider's perspective. So I would most certainly encourage that to be something, especially with your health system hat on, you know, to incorporate, and would encourage all the health systems to do that.
And I'm sorry if I can interject one piece, Commissioner. One service, and I don't think we've actually touched on it. One thing that we do, especially with any provider referrals. So if you know a provider is actually referring to us, whether it's through fax, the web referral, or if we can set up an e-referral, that's great. We actually do send back provider feedback forms. So as that participant is going through the program, they're event-based. So when we receive a referral, we're communicating back to the provider to say, hey, we've received this, when they've enrolled, if they've disenrolled, you know, we have certain pieces that go back just so for your information. So if it's something where we can incorporate that in, whether it's again an e-referral, easy way to do it. But if you go on to the website, onto that QuickLogic site for Connecticut, you can actually put all your information or that participant's information in, and then indicate that you'd like to receive those feedback forms. Obviously, that's for HIPAA covered entities. It wouldn't be for CBOs, for the community-based organizations, but for any HIPAA covered entity, we are sending that information back, whether it's fax or email. If it's an e-referral, we'll actually drop it directly into their system, into the system itself. So just to sorry, something we hadn't talked about, so I wanted to kind of.
Yeah, no, that's really helpful, good feedback to know you do that. And so for the provider and patient who actually wants to go through those steps of, you know, well, we can do a referral right now, and why don't we do, and, you know, sort of walk the patient through that. That's great. And for those, but at a minimum, a very minor lift is including just the information. This is how the patient themselves can reach out. So I think both are important.
For those following on CTN, I just want to call out some really good conversations and synergies that are happening in the chat, and appreciating that Dr. Hahn has offered his email address. David, if you have access to the chat, you'll get his email address, and he's happy to discuss and do some follow-up with the Epic integration and e-referrals. And then Allison also pointing out the importance of trying to build the e-referral champion network. So she's going to reach out separately from DPH. So it's great when we can showcase an intervention that's able to deliver immediate impact and then find ways to broaden the size and scope of it. So thank you. I now have Senator Tony Harp and Dr. Zollner. You'll always be a senator in my mind, Tony.
Well, thank you very much. Dr. Zollner, I think, was before me. So go ahead, Doctor.
Thanks, Senator. Quick question, Dave and Allison. Do you have any idea about how this year's enrollment numbers compare historically with our prior quitline provider?
Yeah, I'll have to defer to Allison on that. We have this year, we wouldn't have access ourselves to last year, but.
Yes, Andy, I can gather that information to provide a comparison. I can certainly do that to share with the group.
Thank you. That's great.
Just as one follow-up, though, I do want to comment on, it was a very small fraction of a contract that we had in terms of prior. We had $100,000 going towards quitline previously versus millions of dollars that we're doing now. So just even in the framework of what we're doing, this is of a scale and magnitude much greater than we were doing at all. And that was just based on the CDC grant that we had.
Thank you.
So I just want to thank Claudio and the staff for this really informative discussion of what is our largest initiative, I believe. Correct me if I'm wrong, because I think that we've learned a lot, and I believe that I'm going to ask that we, after this meeting, have discussions around where we want to go in the future, whether we want to engage in enhanced contracting or what it is that we really want to get from that. I just have one question beyond asking for that, and that is, I was kind of intrigued when you said that you ask for insurance information, and I was wondering what you do with that information once through the intake process for potential clients. Is there any way that their insurance can give them enhanced services, or just how is it used?
No, good question. And that does vary, honestly, by state. So we do ask the question. That's one of the MDS questions for insurance-based information. That is reported back in this case, since all participants in Connecticut do receive full service. That's obviously reported back to the state, to the demographic reporting. With that being said, I will say that other states do use that data, or we use that data on their behalf to identify benefits. So in some states, their commercial insurance bears the full weight of the participant. Whether we would either send that participant directly to the commercial insurance, or that might limit their NRT abilities when we refer them over. So that's some of what we use that particular information for.
So does it actually provide an access for more NRT if their insurance would cover it? I don't know. It might be something for the department to pursue.
Yeah, and as I referenced, when we have exceeded met the allotment of NRT eligibility for that participant during the year, we do refer them back to their insurance to find if they have any additional benefits for NRT coverage. That is part of the conversation that we do have with them to refer them back.
Thank you.
Mm-hmm. Thanks, Sarah. Were there others?
I don't see any other hands raised. So I appreciate this, and I'm glad that we were running ahead of schedule, because you were great to fill the time and give us a lot more information. So Appreciate it. And I'm sure we'll be hearing more from you and take back some of the ideas from this conversation.
No, and thank you for having me today. So thank you very much.
Of course. So that brings us to the almost next to last item, which is I just want to highlight the next meeting and some steps that we plan to do. Obviously, we'll continue to have our standing agenda items, which is the update from DPH on project status and the process for contracting and getting those resources out and in place. And then we'll also plan to have an update on the fuller budget picture, including any interest that may post. Additionally, I think we want to spend most of our focus time on a presentation from our Tobacco and Health Trust Fund program evaluator. That was always a top priority for this group going into it. We want to be mindful and smart with the resources and how we invest them. That's why we dedicated such a significant portion to having a program evaluator to measure outcomes. And it'll be good to set aside the bulk of our substantive time together to hear from them. And then obviously, if there are other items of interest from the board, I would encourage you to send an email to Melissa and myself just so that we could gather where the board members want to spend a little extra time and try to, as best as possible, accommodate those requests. With that, I'll turn to an opportunity for public comment. I'm not sure if there's members from the public that wish to speak, but I do want to just pause for a minute and give folks an opportunity for public comment. Seeing no requests for public comment, I'll close the public comment period and then ask for a motion to adjourn today's meeting. Do I have such a motion?
So moved.
Thank you, Dr. Sullivan. And it's seconded by Isha. Thank you. All those in favor for moving adjournment, please signal by saying aye. 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 Any opposed? Any abstentions? Seeing none, we are adjourned. Thank you. Have an enjoyable rest of the summer and look forward to reconvening next time.
Thank you. Bye-bye.